A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. In our last talk, we've been mentioning about hypertension in pregnancy, and we've discussed some of the salient features of hypertension in pregnancy, which is so common in the African subcontinent or in the African continent. In continuation, we would now like to talk about preeclampsia superimposed on chronic hypertension. We know what chronic hypertension is. Chronic hypertension is high blood pressure which is present even before a lady becomes pregnant, and this affects 10 to 25% of patients who have chronic hypertension. So, nearly 1/4 of ladies who become pregnant may go on to preeclampsia, which is superimposed on chronic hypertension. Our feeling is that these are Western figures. It's quite possible that in Africa, in the hospitals where you work, this incidence may be much higher, and this may be particularly true in the rural setting of Africa, where most of our medical clinics are or hospitals are. Because of lack of education, many patients who are pregnant do not know about their chronic hypertension, because we know that hypertension is a silent killer. It remains silent till a patient develops a complication. So, the first time blood pressure may present as a complication during pregnancy, and the incidence may be much higher than what we talk of 25%. To my mind, it may well be about 50%. So, the additional signs and symptoms which may occur in preeclampsia, which is superimposed on chronic hypertension, is a new onset proteinuria. The patient may already be having bit of proteinuria, which is insignificant or very mild, but then it suddenly increases after a patient becomes pregnant, particularly after 20 weeks of gestation. So, a combination of hypertension, the figures which we mentioned, and proteinuria will or should lead you to the diagnosis of preeclampsia in those particular patients. There may be sudden increase in blood pressure. A blood pressure which was 140/90 suddenly increases to 170/110. That is an indication, particularly if it is combined with proteinuria, which is greater than 1 grams in 24 hours. Thrombocytopenia, which is reduced platelets, as we talked about last time, a count of less than 100,000. Platelets are important because platelets are one of the clotting factors, and if in hypertension platelets become fairly low, then there is a greater chance of bleeding in these patients, whether it is cerebral bleed, retinal bleed in the gastrointestinal tract, or uterine bleed. So, these patients can bleed excessively and may become severely anemic, or their liver enzymes may be disturbed and they may have a rise in ASTs. So, preeclampsia superimposed on chronic hypertension has basically the same signs and symptoms, but they occur relatively acutely and they are more severe. And the treatment is fairly simple. Simple in the sense that the patient must be delivered, but that is not always possible, because at 20 weeks the child would not, the baby would not survive. And the major indication for giving antihypertensive treatment is the prevention of stroke. Now, if I ask this question, why prevention of stroke is so important? Why should we prevent stroke? I think the answer lies that stroke causes a major disability. A young lady who is 25, 30 years of age, pregnant, becomes hemiplegic. So if the baby survives, then she may not be able to take care of the baby or herself or do the household work, which is so important in the villages of Africa, and she is left disabled for the rest of her life. So prevention of stroke is extremely important. Diagnosis, blood pressure measurement, urine examination is so important so that we can prevent stroke in these cases. So you can well understand that talking of hypertension in pregnancy will reduce strokes. If you reduce hypertension, you will reduce strokes to a large extent. Even in general population, in men or women who have hypertension, the commonest presentation of these patients is not heart attack in Africa, it is stroke, because it remains silent for a long period of time. For the first time when they come to the hospital, they come with various signs and symptoms of either an evolving stroke or a well developed stroke. And once stroke develops, it is a great liability for the family, for the other family members. If a person, male who is 40 years of age or a female who is 30 years of age, then you have condemned him for the rest of his life, because they are no longer useful members of the society, in the sense that they cannot make two ends meet. So the vicious cycle of poverty then continues. So I think we ought to realize, and most of the doctors whom we are now addressing to, I know you know it much better than myself, that periodic examination of blood pressure and periodic examination of urine is so important in order to reduce the complications of high blood pressure in these particular patients, particularly in patients with pregnancy. And if you reduce the blood pressure to less than 90 diastolic or less than 140 systolic, then you reduce the chances of stroke considerably. But if the diastolic pressure is greater than 105 or 110 and the systolic blood pressure is greater than 160, the chances of stroke are very, very high. And in pregnancy, when most of the blood vessels are in such a state that they can easily rupture, you can well imagine that a patient who is not pregnant and has similar blood pressure, and a patient who is pregnant and has got that sort of a blood pressure, the chances of developing stroke is much higher in those who are pregnant. So we take lot of care in pregnant ladies who have even slight rise in their blood pressure. And understanding few drugs is so important. I'll just mention that we ought to know just 3 or 4 medicines. That is all what we require. You don't have to learn all the anti-hypertensive drugs which now run into hundreds. Just remember that for acute cases where you have an acute rise of blood pressure in a lady who is pregnant, put her to rest, give her an injection of diazepam, oxygen if possible, most likely you can do, prop up the patient, keep her on one side in case she inhales or she becomes unconscious, have a close watch if she develops some sort of a fit or becomes unconscious so that she may not inhale the vomit, and set up an IV line, and the drug of choice is labetalol. So we must learn about labetalol. What is this class of drug? How this should be administered? In what dosage it should be given? This is the wonder drug of hypertension or preeclampsia in pregnant ladies, you say. Intravenous hydralazine is another drug, which is basically an arteriolar vasodilator. It vasodilates the the sphincters and causes an acute drop in blood pressure. Nifedipine, which again is a calcium channel blocker, which again causes vasodilatation of the arteriolar bed. So, 3 drugs, labetalol number 1, I think to my mind if you know labetalol and you have a stock of labetalol, you are fine. Hydralazine is the second drug, it has its complications. Nifedipine is another drug which can be given, but do not give sublingual nifedipine because that may cause an acute drop and it also has a cardiac toxicity as well. So, remember labetalol as the drug of choice in patients who are pregnant and are going into preeclampsia. Hydralazine is the other drug, it has its few side effects, it has to be monitored, and same is true about nifedipine, and check the blood pressure of these patients every 15 minutes. So, if you have a trained nurse or a trained assistant, or if you are in charge of the case, then the only important thing in these patients is that see and examine their blood pressure every 15 to 20 minutes and try to bring it down to upper normal limits, which is 140/90 say. Do not bring it down too low, and if you achieve that, you have saved the life of the patient. You have saved him from stroke, from acute heart failure, from acute kidney damage or acute liver injury say. Long term, after we have treated the acute crisis, you can switch over to methyl dopa or Aldomet, which has hardly any side effect as far as the baby is concerned or the mother is concerned. It has a few side effects, and labetalol can also be given, which can lower the blood pressure. So, for our colleagues who are working in Africa, I think if we understand the mode of action of these 2 drugs, I am sure we can win a number of patients and treat a number of patients who have pregnancy with hypertension. Talking of gestational hypertension, now this is mild hypertension without proteinuria or other signs of eclampsia. It develops in late pregnancy, particularly after 20 weeks of gestation, and it resolves by 12 weeks after the baby is delivered. But it can progress to pre-eclampsia, and often when hypertension develops in less than 30 weeks of gestation. Antihypertensive drugs are the same as we talked about, but this is a separate category in itself, a relatively milder condition, but needs to be monitored. Again, 2 monitoring are important. 1, blood pressure, and 2, the urine examination. That is right. Now, what are the risk factors for hypertension during pregnancy? The first, pregnancy would be one of the risk factors. There are a number of these risk factors. If a lady has had preeclampsia in the previous pregnancy, this pregnancy may again be complicated with hypertension. Age greater than 40 years or very young ladies less than 18 years. Now, this may be particularly true in Africa because quite a number of young females, the parents get these young girls married at the ages of 13, 14, 15 or 16. That is why there is a much higher chance of preeclampsia or hypertension in these young girls. So, any girl in her teens must have once again those 2 things checked, blood pressure and proteinuria. Usually after the age of 40 in Africa, the childbirth is relatively less because they have born their children much before that. This is after the age of 40 is more commoner in the Western world. So, remember that less than age of 18 years we should be watchful for hypertension in the African continent. If there is family history of pregnancy or hypertension, then chronic hypertension, chronic kidney disease, various other inherited rare disorders, connective tissue disorders, diabetes. Now, this is particularly true in our part of the world, in Southeast Asia, where diabetes is so common amongst ladies, and there is a greater chance of these ladies getting hypertension. What I usually advocate is that if you are working in Southeast Asia, places like Pakistan or India, then besides examination, monitoring their blood pressure and checking their urine for proteins, we must invariably check their urine sugar also. It is not true about Africa, but here the incidence of diabetes is very high. So, you must check them for urine, and if you find that there is glycosuria, must confirm with blood sugar, because we know that you can have sugar in the urine during pregnancy, and this must be confirmed by blood sugar estimation, because that sugar is slightly different as compared to to glucose, which we normally check. If there is multiple, if there are twins or triplets, then there is greater chance of hypertension in pregnancy. Now, this is an interesting point, that if male partner whose previous partner had preeclampsia, there may be some transmission via the male member which may affect these particular ladies. Hydrops fetalis and unexplained fetal growth restriction can also precipitate preeclampsia. So, evaluation of hypertension in pregnancy, we talked about it. We will just summarize it again in this particular slide. In the history, the complaints, the signs and symptoms of preeclampsia, past medical history, past obstetrical history, gynae history, social history, medication or allergies. There are certain drugs which can cause high blood pressure. I do not have to go into the details of that, and some people are used to that. They may be taking drugs, and those people who have a propensity to develop hypertension during pregnancy can have preeclampsia in their pregnancies. And assess these patients for hypertension in pregnancy and risk factors. The physical examination, I think again you have to do a complete physical examination starting from head to toe, including blood pressure measurement in both arms, 2 readings, 6 hours apart, and a urine examination is so important. I personally consider urine examination as a part of physical examination. I consider an ECG a part of a physical examination. I consider a chest X-ray, which you normally do not do in pregnancies, but in the medical side is a part of physical examination. And I also talk about urine for glucose as a part of physical examination. So, in general, when we are talking of the physical examination of the patient, I think besides a detailed physical examination from head to toe, I think it is important, if you have facilities, which many of our hospitals have, not only for pregnancy and hypertension cases, but for others also, do an ECG, particularly if a person is over the age of 40 years, do a chest X-ray, because we know there are certain diseases. Tuberculosis is so common in the third world. Patient may not be symptomatic or may be just having mild cough. A chest X-ray is so important. Urine examination, particularly for proteins and for sugar. These 4 laboratory, radiological, electrocardiographic examination, to my mind, form part of the physical examination. So, in patients who are pregnant and have hypertension, I think you can include an ECG, a urine examination in this examination as well. Laboratory tests, we see, we have talked about it, that a complete blood count, Dr. Faiza will tell us what should the blood count show in a person who has hypertension during pregnancy or has preeclampsia.
Sir,
The hemoglobin?
Feared complication is HELP syndrome.
Right.
In HELP syndrome, there will be hemolysis, so HP will drop.
Okay.
And there are low platelets, so platelets will drop. So CBC will show us the same. If we want to do the peripheral picture, blood picture will show us the retics count, which will be high, and that's all.
Yeah, that's right. That's right. Very right. And Dr. Razi, what about the renal functions?
Renal function we mostly include urine, the urea and the creatinine. These shows about the proteinuria and the renal impairment, which can be caused by due to hypertension. So in order to control the hypertension, we need to constantly monitor the blood pressure along with the urine analysis, and to compare with this, we have urine electrolytes also. We can check them, and the urine and creatinine levels are specifically significant in the evaluation of hypertension, especially in the pregnant ladies.
Great, that's very nice. And Dr. Faiza, what about the liver functions? Why are they important?
Sir, they are also important. The pregnant lady, if she says that I have right upper quadrant pain, so we will go for LFTs. So if the LFTs are high, as you have told, the cutoff limit, that is 75. If they are more than 75, it means the LFTs are deranged, and she has the chance of developing HELP syndrome.
Right, good. So I think managing these patients after having diagnosed them, done the laboratory tests, obviously management would depend on the severity of hypertension and the age of pregnancy or the duration of pregnancy. These patients need very close observation and monitoring. In our hospitals in Africa or the medical clinics in Africa, again for our doctors and those assistants who work in hospitals, it is important to train the patient and their family. I think the very intelligent people, our villagers are also very intelligent, the African nation is very intelligent. So if you can train them to take blood pressure, or if you can train them to do a dipstick urine estimation, I think it would be greatly helpful in diagnosing this particular condition fairly early, so that they can come to the hospital, because proteinuria is a painless condition. A blood pressure of 140/90 again is silent. The patient will only come to you if there is a complication which has occurred or if the disease is too advanced. Supposing we detect this early, and if this is detected at a level by the family or by a medical attendant, then I think you can treat the complications very or reduce the complications and treat the patient very early. We talked about the medical management, again the acute management and then the chronic management. Dr. Faiza did ask this question about the contraindication of certain drugs, and we said that which drugs are important to remember?
Sir, most important is IV labetalol.
In acute setting,
acute
IV
setting.
labetalol or oral labetalol follow-up.
Oral.
And any other drugs?
Sir, methyl dopa is
Methyl
also
dopa. So I think if we know these two drugs, I think the battle is won to a large number of these cases. And the only cure is?
delivery of the baby.
So only cure is. It is interesting that as soon as the baby is delivered, the blood pressure stops coming down within days or within hours at times. To the complications, if they had set in, like papilledema, like disorientation, proteinuria, etc., they all start improving within hours to within days or weeks. So the sooner the child or the fetus is viable, I think we should try or attempt to deliver the baby. And if the mother is threatened, or if she is developing complications, then irrespective of the age of gestation, I think deliver, and you can save the life at least of the mother. So, if we just sum up the entire story of hypertension and pregnancy, I think one, Dr. Faiza, will you tell us what is the level of blood pressure which we say as the limit?
Sir, the target blood pressure level should be 140/90, and if it increases, and especially it should not be one reading. There must be two readings 6 hours apart.
Right. So that is the criteria.
That is the criteria. Yes.
So, Dr. Nadi, which are the how would you monitor these patients? Which are the two important monitoring modalities which you would like to take up?
Sir, in managing these patients, we have to monitor two things. Now, as Dr. Faiza mentioned, the criteria of blood pressure. The blood pressure needs to be constantly monitoring, and the second thing is the urine analysis, the urine reports. We study the urine laboratory diagnostic tests along with the blood tests, like you mentioned CBC, and we've discussed about the platelet counts and hemoglobin, along with the electrolytes, and along with all the diagnostic parameters like ECG. As you mentioned, there is electrolyte imbalance, and we can detect it over the ECG, and it's on the first hand we have the ECG machines available in all our institutions. So, managing all the things and getting all together the things, we can further evaluate and heading towards the steps to controlling in a better way for the hypertension, and thus we can get a better results in the pregnancy. And lastly, we need to save life, and life matters.
Right.
For
okay,
the mother.
Which complication you dread most
Sir,
in patients who have preeclampsia or hypertension?
Cerebrovascular accident,
Right,
because they cause disability, and this is the most feared complication of preeclampsia
Right.
and eclampsia.
So, if you have a patient like this who has come in with severe preeclampsia, which are the methods of managing these patients?
So, for the acute cases, we have labetalol through intravenous administration route, and then we have nifedipine, and for the long term we have methyl-dopa and the levetiracetam through oral routes for managing these kind of patients.
Okay, that's very nice. And what is the ultimate,
Sir,
in inverted commas, cure for patients of preeclampsia?
deliver the baby.
So, deliver the baby.
And
I
save the
think that's
mother.
right. So, dear colleagues, I think in this particular session we have covered some of the other aspects and revised what hypertension in pregnancy is, what is the incidence of the disease, how should we diagnose it, what is the level of blood pressure which we should be careful about, how should we monitor these patients in the most simple way, which are the important drugs which we ought to remember, and which are various tests which we have to do in these patients. And I think if we understand the basics and the simple things, I think we can treat over 95% of our patients effectively, as better as any patient in the West. Jazakumullahu ahsanal jaza.